Good morning. We will be continuing with the beta-lactam antibiotics. In the previous class, we discussed penicillins, their classification, mechanism of action, uses and adverse effects. In today's session, we will be discussing about cephalosporins and the Monobactam group of antibiotics. Cephalosporins are obtained from this bacteria of the Cephalosporium species. Now the mechanism of action, as we mentioned, cephalosporins are beta-lactam antibiotics, therefore their mechanism of action is similar to penicillins. So by binding to penicillin binding protein of the bacteria, the cephalosporins inhibit the two enzymes transpeptidase and carboxypeptidase. Therefore, cross-linking of N-acetylmuraminic acid and N-acetylglucosamine is inhibited. This results in inhibition of peptidoglycan synthesis. Therefore, bacterial cell wall synthesis is inhibited, resulting also there is inhibition of bacterial autolysin. So the bacteria which are thus formed are deficient in cell wall, resulting in increased intracellular osmotic pressure. The bacteria ruptures, bursts and dies. So like the penicillins, cephalosporins are bactericidal. Since mycoplasma do not have a cell wall, cephalosporins are ineffective against mycoplasma. Just like how bacteria develop resistance to penicillins, they also develop resistance to the cephalosporin group of antibiotics. The mechanisms being alteration of the penicillin binding protein, or by becoming impermeable to cephalosporin, and some bacteria produce enzymes, in this case cephalosporinases or beta-lactamases, which break down cephalosporin. The classification of cephalosporins is based on the spectrum of activity, and they are thus divided into 5 generations. The first generation cephalosporins are mostly effective against gram-positive organisms like Streptococci and Staphylococcus aureus. If a drug is mentioned with P in the bracket, it means it is administered parenterally. The first generation cephalosporins, some of the examples include cefazolin, cefalotin and cefalexin. So please note the examples given here. First generation cephalosporins have this Fa in the spelling: cefazolin, cefalotin and cefalexin. Second generation cephalosporins, in addition to being effective against the mentioned gram-positive organisms, they have activity against few gram-negative organisms like E. coli, Klebsiella, Proteus, Haemophilus influenzae, Moraxella catarrhalis, and also extended activity against Bacteroides fragilis. Some of the examples of the second generation cephalosporins include cefuroxime, cefoxitin and cefotitan. So to remember second generation cephalosporins, fur, fox and tet in the spellings. Third generation cephalosporins lose activity against gram-positive organisms and become more active against gram-negative organisms like the Enterobacteriaceae, Pseudomonas aeruginosa, Serratia species and Neisseria gonorrhoeae. Third generation cephalosporins is a frequently asked 5-mark question. So cefotaxime, ceftriaxone and cefoperazone. These are some of the examples of the third generation cephalosporins. Now what happens with the fourth generation cephalosporins is they regain activity against gram-positive organisms. So the fourth generation, we have 2 examples, cefpyrone and cefepime. These 2 drugs are examples of fourth generation cephalosporins which are active against gram-positive and gram-negative organisms. In addition, they are also somewhat, not totally, but somewhat resistant to beta-lactamases. Fifth generation cephalosporins, example ceftobiprole and ceftarolin. These are still in clinical trials, not yet available for use on patients. Coming to some of the uses of the cephalosporin. So the uses will be based on its spectrum of activity. The first generation cephalosporins for minor staphylococcal infections and polymicrobial infections. Second generation for sinusitis, otitis, respiratory tract infections and pneumonia. Third generation cephalosporins are the first line drugs in gonorrhea and meningitis. Fourth generation, the uses are similar to what we mentioned for third generation. In addition, also used to treat Enterobacter infections. Fifth generation cephalosporins, namely ceftobiprole and ceftaroline. These are effective against Staphylococci, E. coli, Klebsiella and Haemophilus influenzae. They are not yet available for routine use in treating patients. They are still in clinical trials. The adverse effects of the cephalosporins. Injectable cephalosporins, pain at the site of injection. Oral cephalosporins adverse effect, diarrhea, hypersensitivity reactions including anaphylactic shock, nephrotoxicity, bleeding diatheses, neutropenia, thrombocytopenia and a drug interaction with alcohol, namely disulfiram-like reaction. Then cephalosporins are used as alternatives to penicillins in urinary tract infections, respiratory tract infection, soft tissue infection, penicillinase producing staphylococcal infections, septicemias, surgical prophylaxis, meningitis, gonorrhea and also for mixed aerobic and anaerobic infections. Coming to the carbapenems. These are extremely potent antibiotics with a broad spectrum of activity. Carbapenems are effective against gram-positive cocci, Pseudomonas and very important Clostridium difficile, which causes pseudomembranous colitis. Imipenem is a carbapenem. When it is administered alone, it is rapidly hydrolyzed in the kidney by an enzyme dehydropeptidase. Now this can be prevented by combining it with cilastatin. There is a mistake here. Please correct this to cilastatin. Cilastatin inhibits renal dehydropeptidase. So imipenem is always combined with cilastatin, which is given intravenous every 6th hourly and is mostly reserved for hospital acquired infections. So please make a correction here. This is cilastatin. So imipenem cilastatin is a frequently asked 3-mark question. The reason is imipenem rapid hydrolysis by renal dehydropeptidase. Cilastatin is a dehydropeptidase inhibitor, therefore prevents the breakdown of imipenem. Meropenem is not hydrolyzed by dehydropeptidase and is a reserved drug for hospital acquired infections. Both meropenem and imipenem, like we mentioned earlier, need to be given intravenously. Whereas pharopenem is orally active against both gram-positive and gram-negative organisms, again reserved for hospital acquired infections. Used in respiratory tract, ENT and genitourinary infections. Ertapenem is given once daily intravenously, active against Enterobacteriaceae and anaerobic organisms. Used for intra-abdominal and pelvic infections, again hospital acquired. Now we come to the monobactams. The example we have here is aztreonam. It contains a single ring, that is a monobactam, derived from bacteria, so the bact part of its name, and is a beta-lactam. So aztreonam is a monobactam, effective against gram-negative aerobes like E. coli, Klebsiella, Proteus and H. influenza. Now since it is a beta-lactam, the mechanism of action is just like penicillins, that is binding to penicillin binding proteins, inhibiting carboxypeptidase and transpeptidase. Therefore, interlinking of NAM and NAG is blocked, peptidoglycan synthesis is blocked, cell wall deficient bacteria, increased intracellular osmotic pressure, the cell bursts and is bactericidal. High doses of aztreonam are effective against Pseudomonas. Aztreonam does not have cross-allergenicity with penicillins and cephalosporins except ceftazidime. Aztreonam is penicillinase resistant but is orally inactive. That means it is broken down by gastric acid. Given intramuscular or as an intravenous infusion twice or 3 times a day. Like the penicillins, it is excreted unchanged by glomerular filtration. Adverse effects include gastrointestinal upset, skin rash and neutropenia. Coming to the uses of aztreonam. As an alternative to aminoglycosides in gram-negative infections. Neonatal gram-negative infections and in patients allergic to penicillins and cephalosporins. Ceftriaxone is a frequently asked 5-mark question. So which generation does this belong to? It's a 3rd generation cephalosporin. So what will be the mechanism of action? Similar to what was mentioned for the penicillins, that is binding to carboxypeptidase and transpeptidase. Therefore, inhibition of cross-linking of NAM and NAG, inhibition of peptidoglycan synthesis, cell wall deficient bacteria, increased intracellular osmotic pressure and rupture of the bacterial cell, and also inhibition of bacterial autolysin. Pharmacokinetics excreted unchanged by active tubular secretion. Given intravenous or intramuscular once or twice a day with a plasma half-life of 8 hours. Ceftriaxone is also excreted in bile and crosses the blood-brain barrier. So ceftriaxone is used in bacterial meningitis, typhoid, urinary tract infections, abdominal sepsis and septicemia. 250 mg intramuscular single dose in penicillinase producing Neisseria gonorrhoeae infection and in chancroid. So this can be a question in the viva. For uncomplicated gonorrhea, what is the single dose drug? 250 milligrams of ceftriaxone, single dose intramuscular. Adverse effects of ceftriaxone include bleeding, hypoprothrombinemia and hemolysis. The other adverse effects like nausea, vomiting, allergic skin reactions, including anaphylaxis. Now, since ceftriaxone is susceptible to breakdown by penicillinase, it is combined with a penicillinase inhibitor, that is a beta-lactamase inhibitor, sulbactam or tazobactam. In typhoid, ceftriaxone is given 4 grams intravenous for 2 days, followed by 2 grams per day till 2 days after fever subsides. Why is it given for 2 days even after fever subsides? To get rid of the salmonella which are present in the gallbladder. So this completes the topic of beta-lactam antibiotics. Thank you.